looking at Retatrutide, the difference between Glucagon and the other earlier acting GLP-1s is this additional receptor.
What are your thoughts around the affordability of this and the accessibility of this peptide, or do you even know?
I think it's
This is the topic that everybody wants to hear about right now. First, we had semaglutide. It targeted the GLP-1 receptor, and the weight loss was like we've never seen before. Then we had tirzepatide. It targeted the GLP and the GIP, and somehow had less side effects than what we saw with semaglutide. Now we have retatrutide, which targets the GLP, the GIP, and the glucagon receptors.
Yeah, and it's not going to stop there. There's phase 1 going on right now, trials of this quad receptor. So this science of GLP-1s is going to continue to move in the direction, and I love it. I love it. The ingenuity and what they're going to find and what they're going to figure out is amazing. And GLP-1s really are revolutionizing the space of overall health, not just, literally almost all health. I think in the next 10 years, we're going to see so many different conditions where GLP-1s are going to be considered the first line of treatment or part of a comprehensive protocol. Right now, we are looking at Retatrutide, the triple G. And the thing about the difference between Glucagon and the other earlier acting GLP-1s is this additional receptor. Semaglutide is your GLP-1, Tirzepatide opens up the GIP. Now, for GLP and GIP, they're pretty similar. So you don't get a huge difference between what's happening. Couple subtle differences. One cool aspect of tirzepatide, and this was actually more recent research looking at fat cells. Specifically, there are GIP receptors on the surface of fat cells, which there are no GLP-1 receptors. Therefore, there are activation on these surfaces of these fat cells, and that leads to more fatty mobilization. And that's probably why tirzepatide has better results. Now, retatrutide, the third receptor that it's hitting is very different. And so we have to understand that it's not the same sort of transition that we noticed from Sema to Terz. From Terz to Reta, it's a little bit different. We are incorporating the glucagon receptor. And glucagon is kind of like, and I know we'll get more into it later, so it's like the Lex Luthor to Superman here, being insulin.
Looking at specifically the mechanism of action and why you believe that there's going to be more efficacy in retatrutide, in more practical terms, what types of results do you see that are going to be enhanced with retatrutide as opposed to the other GLPs?
I think we're going to see better fat loss and we're going to see better muscle protection. The weight loss from tirzepatide is already great. Are we going to see more pounds off the scale? Probably. But I think we're going to see a better shift in the ratio, which is what we ultimately want, because that is a much better indicator of metabolic health improvement. The weight can go down and you're always going to get some amount of metabolic improvement, almost always, although there's certainly cases where the metabolic health doesn't really improve much at all if you're losing mostly muscle. But for most people, taking GLP-1s, losing weight, even the ones doing the worst sort of scenario, no weight training, not eating enough protein, they're at least getting a lot of fat loss, probably some visceral alongside a lot of muscle mass, not optimal for sure. But with retatrutide, because we are stimulating lipolysis directly, remember glucagon is raised when you're fasting, when you're not eating. It does the opposite. It's increasing blood sugar levels when it's low. So we have something that mimics fasting and which increases ketone production. And so this is metabolic flexibility.
But let's get to the safety concerns, because one of the things that seems to be popping up over and over again with questions on safety is what the hell is going on with the cardiac function, the effect on the heart. Is there any rhyme or reason or any real reason to be skeptical or to believe that this actually might be risky from a cardiac perspective?
Well, I think absolutely, because we're talking about something that's not through phase 3 clinical trials. So there's just not enough people that we've done the studies on. They did I think it was like 338 people in this phase 2 trial. And to be clear, a very small number of people actually had some heart issues happen, and only one was considered serious. And so the rest of them were what we call supraventricular tachycardia, which is essentially like an increase in heart rate at certain parts of the heart. This is almost never fatal. And these instances were mild to moderate at worst. I do think there's a little bit of an additional pool of people that shouldn't possibly take retatrutide that are fine to take semaglutide or Tirzepatide because like I said earlier, glucagon is definitely another beast. I think it's a little bit more of an upper. It's definitely more stimulatory for sure. And we see it here. But when you look at the size of the study and the fact that we're talking about less than 4% of people, I mean, you never get the exact numbers from these studies, but my guess would be probably 3 to 6 people. But overall, we're looking at a family of medications that we know are, relatively speaking, very safe and very well studied. And so it's not too far-fetched and out the realm to continue to think that you're going to see more and more safety. But yes, each one, especially like this, adding this additional set of receptor being glucagon, what we need to know about it is important. And absolutely, because it hasn't passed phase 3, I think any phase 3 approved medication, when available, should always be the option first. Depending on when you guys are watching this, yesterday, the day we're filming this is the day that the FDA made real the fact that they are standing to their position that Tirzepatide is no longer in a shortage. So access to compounded Tirzepatide is finito, is donezo. They gave a grace period till February. So we brought it in so that we can get some comfort with it, so we can get some experience, and we being my providers, not me, because they do the prescriptions. But I like to study this stuff. I'm a nerd. I like to nerd out and really understand, because when I coach them on lifestyle, I got to have an understanding too as well. And then I meet with my providers and we do this sort of stuff every day. But I think if it were the only option to an obese individual and we encourage them on the lower dosing side, I think people are freaking out for no reason. Retatrutide fits into the flow protocol no different than any other GLP-1 medication. It's a tool to allow you to implement lifestyle changes. At the end of the day, the safest way, in my opinion, the most effective way for permanent resolution, permanent maintenance of weight, is permanent maintenance of metabolic health. Permanent maintenance of a metabolic health is permanent changes in your lifestyle. But there's a big but there. Without the medications, this is very daunting. This is very overwhelming. This is very challenging, which is why I love the combination of both. And that's really what Flow has become. And that's what me and my medical practitioners were so passionate about, is just bringing the best of both worlds together. As somebody who has lived this myself for about 8 years after I first lost over 100 pounds when I was 16, that to me is the successful strategy. It's done me well and the thousands of people that I've helped so far. So that's what we do.